Today's lecture is going to be about the uninterrupted maxillary canine. We'll discuss some cases on campus and look at it further. Um, we're going to start with the outline of the lecture. We're going to have a little introduction, prevalence, etiology, talk about root resorption of the upper lateral, investigations used, prediction, prognosis, and treatment options. Let's start with the definition. So an impacted canine is a canine that is prevented from eruption into its normal functional position by bone, tooth, or fibrous tissue. There are two types of impaction according to Richardson: dental and bony. It's important to know the normal eruption times so that you know that a tooth is impacted or not. In the maxilla, eruption of the canine is usually 11 to 12 years, in the mandible 9 to 10 years. It's very important to know that also that the maxillary canine should be palpable in the buccal sulcus at the age of 10 years, and we will talk a little bit more about that in detail later on. So what's the prevalence of impacted maxillary canines worldwide? In European population, Erickson and Kurl found that it is about 1 to 2%. We did a study in 2001 and found that in Jordan it was higher, it's around 4.7%. And developmentally absent canine, that is congenitally missing canines, is very, very rare, and that is 0.08%. And this is work done by Byrne et al. Or Bryn et al. The palatal location is the most common for impacted maxillary canines, and it's twice as common in girls compared to boys. The best way to diagnose an impacted canine is a CBCT now, and that's the gold standard these days. Although you'll see that a lot of the prognosis that we depend on or assess is on OPG still, because we don't have any CBCT data. However, I think it's coming. So etiology of impacted canines: long path of eruption. Canine takes about 22 millimeters to, it starts up near the orbit and goes all the way down into its position. And this is the work done by Richardson. Sometimes the displacement of the crypt or the bud. Problems with maxillary lateral incisors. And this is the work done by Becker et al. They found that if there's a congenitally missing lateral or a peg-shaped lateral, small lateral, it's 2.4 more times more likely for there to be an impacted canine. So they're associated with problems with maxillary lateral incisors. Jacobs talked about crowding, primary retention of canines, retention of primary canines, that's another etiological factor. Mesial dilaceration of the upper 4 roots. So if the root of the upper first premolar is dilacerated mesially, that may prevent the eruption of the canine and cause its impaction. Trauma to the anterior region of the maxilla. Obviously that may cause ankylosis of anterior teeth and therefore cause impaction. Pathology, odontome, supernumeraries, and generalized abnormal delays in eruption. The theories of impaction of maxillary canines, there's two main theories. One is the guidance theory, and that's introduced by Becker, and we talked about that earlier. The idea is that the distal surface of the root of the lateral incisor guides the canine to erupt in its position. It acts like a guide or a track that the canine follows. So if there is a missing lateral incisor, the canine gets lost. It loses this guidance. And Becker found that 12.6% of patients with missing lateral incisors had palatally displaced canines. So it was 6 times more in the general population. And this is something that An-Nimri and Absul did. And this An-Nimri's work is in Just in the north of Jordan. The other theory is the genetic theory. and this is introduced by Peck et al. And genetic theory basically means that you have a genetic predisposition, so it's a familiar thing. It's a familiar thing, genetically determined that you're going to get these impacted canines. Okay. One of the main problems with impacted canines is root resorption of the lateral incisors, of the upper lateral incisor. And this is why we have a lecture on impacted canines, because they cause a serious, or they may cause a serious functional problem. Now, the incidence of root resorption associated with impacted canines was estimated by Erickson and Koorol to be 12%. This is when they used normal radiographs. They were using OPGs. When they used CTs later on, in 2000, they found that the incidence increased to 48%. So that's almost half of impacted canines. If you have an impacted canine, there's a 50% chance, 48% chance that there is root resorption of the lateral incisor. The risk factors are females, less than 14 years old, if the impaction is horizontal and palatal, advanced root development of the canine, so the older the older the patient, the more the problem, and canine crown medial to the midline of the two. And we'll talk about this a little bit more later. So if the tip of the canine is mesial to the long axis of the two, or the midline of the two, this increases the chance of root resorption. So let's have a look at this patient. This is a young lady who has an impacted canine, because if you look, the contralateral canine has erupted. It's obviously not due to crowding. There's plenty of space for that canine to erupt. And because the contralateral has erupted, we're assuming that this tooth may be impacted. We take an OPG, and we see that there is this canine. If you can see, you've got the upper left canine, you can see that the canine is overlapping the root of the lateral incisor, and its angulation is mesial, and it hasn't erupted. Now, if you look closely at this OPG, I'm not sure if it's clear, but you could probably see the outline of the root of the lateral incisor, and it doesn't appear on this OPG. There doesn't appear to be any root resorption. We took a CBCT for this young lady. If you look at the CBCT, you can see that the lateral incisor root is resorbed. The apical third is resorbed. And you take another slice, you can see actually that the central incisor also shows some root resorption. So on the OPG, there were no signs of root resorption, but when we took a CBCT, we found that both the lateral and the central were resorbed. So the gold standard now really for assessing root resorption in any impacted tooth, especially canines, is a CBCT. So what investigations should we do? So we start with our clinical investigations. Inspection. You need to search for a canine bulge, and we talked about this. At age 10, you need to palpate the labial sulcus in the canine region and see if there's a bulge. You should be able to feel a canine bulge. You also look at the inclination and the color of the adjacent teeth. So this is first inspection. Then we talked about palpation in the labial sulcus. You also want to palpate palatally. So if you don't feel a bulge in the labial sulcus, you want to go and put your finger, palpate with your finger in the palate and see if there's a bulge palatally. You also want to palpate for mobility of the C, the upper C, and the upper lateral incisor. So we start by inspection, looking, and then palpation, and finally radiographic examination. And this is where we use parallax to determine where the tooth is buccal or palatal. And there's two types of parallax that you can use. You can use horizontal parallax, is where you use two periapicals and you shift the cone about 20 degrees each time. But usually with canines we do vertical parallax. So we'll take an OPG and an upper occlusal. And we'll go into a little bit of detail about that in the next slide. So here's an OPG for that previous patient. An OPG is taken at about an angle of 0 or minus 1 or 2 degrees. So that's a horizontal, we're looking at vertical parallax. Then we're going to take another OPG, we're going to take another radiograph, and this is a periapical radiograph. And this periapical radiograph is taken at an angle of around 60 degrees. Upper occlusal is taken around 60 degrees. So this is taken, so we have shifted the cone upwards, okay? Now, when you're doing horizontal parallax, when you're doing vertical parallax, you need a horizontal reference point. What does that mean? Now, we know that if the tooth moves in the same direction as the cone, then the tooth is palatal. If it moves in the opposite direction of that the cone is moving, then it is buccal. So what we're going to do is we're going to take a horizontal reference on our OPG. So we're going to take the tip of the canine and see its relationship to, let's say, the central incisor. So if you look on the OPG, you'll see that the tip of the canine is at the cemento-enamel junction of the upper left central incisor, right? So that is our horizontal reference. Now, the cone, the X-ray beam, X-ray cone, is moving up, okay? It's moving up because we're going from 0 degrees up to 60 degrees, okay, when we take our upper occlusal or periapical radiograph. Now, if we look at the periapical radiograph or occlusal radiograph that we have here, the smaller radiograph in the upper corner of this slide, you can see that the tip of the canine now has moved into the middle third of the upper central incisor root. So it has moved apically or upwards. So it's moved in the same direction that the cone has moved. So this means our canine is palatal. If the tip of the canine moved down, okay, or incisally, then the tooth would be buccal. So I hope this explains it. We'll talk about it a little bit more in the lecture, and if you don't understand it, I can explain it to you. Right, moving on to prediction of impactions. Erickson and Kurl did a lot of work on this, and they analyzed, they had a longitudinal study, and the analysis of clinical supervision of maxillary canine eruption. Now, what they found is palpation is perhaps the most important thing that you can do. You as general dentists, this is probably one of the key things you can do to identify impacted canines early. They had 505 children, ages 8 to 12. At age 8, they found that 73% were not palpable. At age 10, they found that 29% were not palpable. So the rest, 29 not palpable, so we have about 71% were palpable. And at age 11, only 5 were not palpable. After age 11, only 3% were not palpable. And this is very important now. Of the 384 palpable canines, 383 erupted normally. So, if you can palpate the canine at age 10 or after age 10, then it will erupt normally. It's a very high percentage that it will erupt normally. Okay, and this is what this slide basically says. So you can see here how you see a little bulge in the first slide, and in the other slide, this is later on, the tooth or the canine has erupted on its own. So when do we need to follow up radiographically? So if you can palpate, no need to follow up radiographically. You can go ahead, ask the patient to go away, and you know that this canine is going to erupt. Now, if there's asymmetry of palpation and a difference in eruption of the canines between the right and left side, then you need to take a radiograph. You can't palpate the canine. And the occlusal development is otherwise advanced. other teeth are erupted normally. So you can't palpate the canine, and maybe the 7 has erupted, which is supposed to erupt after the upper canine. The lateral incisor is displaced buccally. So you see that lateral incisor in the photo there, and it's proclined. Now, proclined and buccally displaced lateral incisors indicate that the canine is likely labial. So the canine is labial or buccal, and it's pushing the root of the lateral incisor palatally, and that's what's causing the lateral incisor to be displaced. Right, so the next study we're going to look at, this is a very important study that was done by Lindauer et al. In 1992. And they found a way to identify impaction of canines early using panoramic radiographs. They had 2 groups of chronologically and dentally age-matched patients, and they were compared retrospectively. There were 28 patients with unilateral or bilateral impacted canines and 28 patients with normally erupted canines. All of them had panoramic radiographs available from around the age of 11.8 to 12.1 years. And what they did is they introduced this sector method, or this method of predicting whether the canine is going to get impacted or not. So they took the relationship between the cusp tip of the canine on the panoramic radiograph, and if the tip of the canine was distal to the distal surface of the lateral incisor root, it's sector 1. If it's between the tip of the canines, between the distal surface of the root of the lateral incisor and the long axis, that's sector 2. Long axis to mesial surface of the root, that's sector 3. And if it's mesial to the mesial surface of the lateral incisor root, is sector 4. It's pretty clear in the diagram. So let's have a look at some radiographs. So this is an example of sector 1. You can see that both of these canines are in sector 1. The tip of the canine is distal to the distal surface of the root of the lateral incisors. Okay. Sector 2, you can see that the tip of the left canine is in the area between the distal surface of the lateral incisor and the long axis of the lateral incisor. And this is an example of sector 3. If you see the right canine, the tip of the canine has gone past the long axis of the lateral incisor and has not passed the mesial surface of the lateral incisor. And finally, an example of sector 4. And you can see the left lateral incisor here. It's crossed the mesial surface of the lateral incisor and is overlapping the central incisor. Okay? So, what is the significance of all of this? Well, they found, if you look at the numbers in red are the impacted teeth, and numbers in blue are the ones that are not impacted. If you see that in sector 1, 68 were not impacted, 9 became impacted. In sector 2, 3 were not impacted, 15 became impacted. Sector 3, 0 were not impacted, and 10 were impacted. And in sector 4, 0 were not impacted, and 7 were impacted. So all the canines in sector 3 and 4 became impacted, and 91% of canines overlapping the lateral incisor became impacted. So sectors 2, 3, and 4, 91% were impacted. However, 9 canines in sector 1 also were impacted. So there is an exception to the rule, and 3 in sector 2 were not impacted. So in conclusion, they found, let's go back, I jumped too quickly. They found that 78% of canines that will become impacted can be identified by overlapping lateral incisors. So if a canine overlaps the lateral incisor, in other words, if it's in sector 2, 3, or 4, you can predict 78% of those will become impacted. And 91% of normally erupted canines can be identified by not overlapping lateral incisors. So if it's in sector 1, there's a 91% chance that it will erupt, it won't be impacted. And if it's in sector 2, 3, or 4, there's a 78% chance that it will become impacted. This is a very good way of predicting the prognosis. There are other factors that we look at in prognosis. One is vertical, and there's the rule of thirds, which was introduced by McCherry in '98. And basically what the rule of thirds says is that you divide the root of the lateral incisor, the adjacent lateral incisor, into thirds, or central if the lateral is missing. You divide the root into thirds. So if the tip of the canine is in the incisal third of the root, then this means that the prognosis is good. If the tip of the lateral is in the middle third, the prognosis is fair. And if the tip of the lateral incisor is in the apical third or above, then the prognosis is poor. Also, treatment time is increased if the canine is more vertical. So the distance to occlusal plane, if it's less than 14 millimeters, the treatment time is about 24 months. And if it's greater than 14 millimeters, it goes up to 31 months. And this is work done by Stewart et al. In 2001. Also, another indicator of prognosis is a study done by Power and Short. And what they did is they also looked at horizontal prognosis. And they drew a line from the long axis of the lateral incisor to the mesial surface of the fore. And they stipulated that if the canine was in between those two lines, so between the long axis of the lateral incisor and the mesial surface of the fore, then the prognosis was good. Angulation to the midline on the OPG, and we'll talk about that in the next slide. I'll explain it a little bit more. Stage of root development, obviously, the more developed the root is, the poorer the prognosis. And the idea is that if the root is not fully developed, there is still some eruptive power. So this means that there's still some eruptive force that will push the canine into its position. And finally, we did some work in Birmingham in 2005, looked at a treatment difficulty index for unerupted maxillary canines. And that gave us an idea of how difficult it would be to align these canines. And we found that the horizontal position was by far the most important factor. So as the canine moves in a more horizontal position to overlap the lateral incisor and then maybe the central, this made treatment more difficult. So if we look at this slide, I'm just going to talk about the angulation. And the way you determine angulation is on the OPG, you draw the yellow line, which is a line that bisects the OPG, and then you draw another line, the green line, which runs through the long axis of the canine. And the angle between the yellow line and the green line, if it's 30% or less, this means the prognosis is good. As this angle increases, the prognosis becomes worse. Okay. That makes sense. It becomes more horizontal. So the more horizontal the canine, the poorer the prognosis. Right, let's look at the treatment options. What treatment options do we have when we have an impacted canine? We can leave it and observe it, and we'll look at each of these when you would do or you would consider each of these treatment options. So we have leave and observe, interceptive treatment, which is the extraction of the primary canine, and that's something you as general dentists can do and can recommend. But there are very strict criteria for that, and we'll talk about that in a little while. Surgical exposure and orthodontic treatment, surgical extraction of the canine, you may want to take it out, and surgical removal and autotransplantation, and that basically means taking the canine out and reimplanting it in its position. And we'll look at each one of these when you would do each one. So when would we leave and observe? Well, if there's no pathology, there's no functional or aesthetic problem, you have a good contact between the 2 and the 4, or the C looks good, aesthetically is good, and has good root length, so the long-term prognosis for the C is good. you have a severely displaced 3 with a risk of surgical removal. So you have a C in a very poor position, canine in a very poor position. Um, you can't align it. It has a poor prognosis. You cannot align it. You can't go in and surgically remove it um, because there's risk of damaging possibly the roots of the lateral incisor or the central or the fore. Therefore, you say, right, I'm not going to touch it. It's aesthetic. There's no aesthetic problems, and I just monitor it with radiographs every 6 to 12 months, and that you just leave and observe. So when would you think of interceptive treatment? And we've heard the name Erickson and Kurol a lot, and they're associated with this. The two studies that you really need to know are Erickson and Kurol and the Lindauer study. Those are the important ones that I would memorize, I'd remember, especially in a viva, for a viva. So when would we provide interceptive treatment? So interceptive treatment is extraction of the deciduous canine at age 10 to 13 years. Erickson Kurol found that if the canine was in sector 2 or more, 78% of the canines will normalize within 1 year if the patient has no crowding. So if you have a patient that comes to you and you can't palpate your canine, you take an x-ray, you find that the canine is in sector 2 or more, 2, 3, or 4. And there's no crowding, like the case we saw earlier. So if you extract your primary canine, 78% of these canines, if the permanent canines, will normalize. Their position will improve after 1 year if there's no crowding. Okay. And this is just an animation to show, what happens. Now, 62% will normalize if there is crowding. So the percentage goes down a little bit. If the 3 is overlapping the 2 root, chances of normalizations are reduced. So as the canine on the OPG overlaps the root more, so as it goes into sector 3 and sector 4, the chances of normalization reduce. Okay. And it's more likely to improve if canine was not past the midline of the lateral incisor. So this kind of confirms or goes in line with the study by Lindauer et al. Let's look at some cases. This is a case, these are cases from Erickson and Kurol. And if you have a look, you can see in clinical case 1, before treatment, our canines are in sector 2 and sector 3. And we've extracted the C, and you can see, this is about 1 year later, how they're both in sector 1. And if we look at the next case, again, we've got one in sector, the one on the right is in sector maybe 2, the one on the left is quite severe, it's in sector 3, maybe even 4, slightly in 4, and if we look at after extracting deciduous canines, they both have improved. All right. Okay, so the next form of treatment is surgical exposure and orthodontic treatment. And this is what we do as orthodontists. If you have good prognosis, so your canine's in a good position, you have favorable patient factors, the dental health is good, the patient's motivated, they're willing to wear braces, they're cooperative. And what we do is we provide space. We have to provide space for the canine if the space is needed. And the space is provided either by distal movement of buccal segments on that side, so we move the molars back, or we extract the fore. Okay? Word of caution, never extract the fore before you know that the canine is not ankylosed. This is very important. A lot of very good orthodontists have made mistakes. They've extracted the fore, exposed the canine, tried to align the canine in position, and the canine turns out to be ankylosed. So what I do is I will, before I extract the fore, if I'm going to extract the 4, I will expose the canine and apply traction to it just to make sure that it's moving. And then when I'm sure that the tooth is moved and it's not ankylosed, then I will extract the 4. So this is a word of advice for all of you thinking to become orthodontists in the future, maybe. Right. If the canine is palatal, usually we will do an open surgical exposure and allow spontaneous eruption. So the idea is that you want the canine to erupt into attached gingiva. When it's palatal, there's a lot of attached gingiva palatal. If it's not too deep, you can just open a window, pack it with a perio pack, and the tooth usually spontaneously erupts, and then you can attach a bracket or something to it and pull it into position. Okay. Sometimes we do closed surgical exposure and bonding of an attachment, and the time we do that, the only time we do that, is if it's very high up and you need to remove a lot of bone in order to be able to bring the tooth, have the tooth spontaneously erupt. With buccally ectopic canines, it's a little bit more tricky because there's less attached gingiva on the buccal. So we have usually two options. Either if the canine is not very high up vertically, we can do an apically repositioned flap, and that's where you open a flap, full thickness flap, and then you lift the gingiva up and you resuture it around the crown of the canine. The closed surgical technique is where you open the flap, you bond an attachment to the canine. Usually it's a gold chain that we can apply a force to so we can align the canine, and then you suture back the flap. So once you've got your canine, you have an attachment to it, or the canine has erupted palatally, you want to apply an orthodontic force to it to get it in line, to try to line it in the oral cavity. And the ways you can apply a force is using an upper movable appliance, fixed appliances, a lower movable appliance, and the traction is done with an elastic chain, ligature wire, and as I told you, also a gold chain. Here are some examples. This is using a removable appliance and using some elastics or rubber bands to bring the tooth into position. Removable appliances provide a lot of anchorage because you have the palate and all the teeth, the festooning around the teeth. With fixed appliances, we can also apply elastics to bring these teeth into position. You need a rigid wire when you're doing that. So the wire used with this type of traction needs to be a stainless steel wire, quite a big stainless steel wire, full-sized one, probably. Okay. We'll talk about treatment time. A study by Bazargani et al. And they looked at how long it takes to align these canines. So they found if the canine is in sector 1 or 2, it took 17 months to align, sector 3, 30 months to align, and sector 4, 27 months to align. So usually what I tell my patients is it's going to take about 3 years. And that gives me some leeway for alignment of the canine. So it does take a little bit more time than normal as the prognosis, as the canine shifts towards the midline, it takes a longer time to erupt or to be aligned. So surgical extraction of the canine. This is quite difficult to sell to patients. We still have patients who come in and think if you recommend extraction of the canine, that the face is going to collapse because the canine is not there. We have general dentists like yourselves pretty soon who think that, oh, the patient can't have canine guidance and we can't extract the canine. Now the canine is just another tooth. A patient with an impacted canine doesn't have canine guidance and they're living perfectly well. You can live a long and productive life with group function. So um, there is an indication. We don't like to extract canines, but there's an indication where this should be done. Poor prognosis for alignment. So if you know, if it's in sector 4, it's vertically very high up, it's at a bad angle, and you know it's of poor prognosis and you can't align it, subjecting patient to years and years of treatment, and then in the end, not getting a good result is not good dentistry. So if it's very poor prognosis for alignment, then you need to think about taking the tooth out. Good 2-4 contact. You have the 2 and the 4 are in good contact. The canine's up in a very bad position. Why should you align it? The aesthetics are reasonable. Poor patient cooperation. You want a patient to undergo orthodontic treatment to 2.5 to 3 years, and they have poor oral hygiene. They've got caries. They've got, this is not a patient. This is not a patient that you're going to want to do orthodontic treatment on. And if there's pathology, obviously, related to the canine that you may have to extract. I'm going to show you a case where I recommended extraction of the canines, and we did actually extract the canines. And in the discussion in the lecture, I will show you this case in detail and how we went through the process of trying to convince the mother and the grandmother to extract these canines. But these are, if you see, they're horizontal, they're vertically in the apical third, they're in sector 4, both of them are sector 4. So they're not really good candidates to be aligned. And these are a couple of canines that we extracted, and the results were very nice. So I'll show you them. Finally, the last method of treatment for impacted canines is surgical removal and autotransplantation. And this is in specific cases where the canine is of poor prognosis, so we can't align the canine. We want there to be an open apex so that it doesn't ankylose, or so it reduces the chances of ankylosis. So ideally you want about 50 to 75% of the root formation to have been complete. Fully formed roots, you end up becoming ankylosed, and that really causes problems for us in the future. When would you think about this? Well, you have a congenitally missing lateral incisor, an impacted canine, which is a poor prognosis for alignment. So you have a central, you don't have a lateral, you don't have a canine, and then you have your premolar. So you've got 2 teeth missing. And this is an instant where it's worthwhile, where you go in surgically, you remove the canine very gently, have the surgeons remove the canine without touching the root, just from the crown, and then they take it out and immediately form a little socket for it in the position next to the central incisor, or whatever position you've decided, and then they just reimplant it, they put it back, they autotransplant it, and we obviously fixate it and then follow it up. And I haven't done it, to be honest. I've had, over the years that I've been an orthodontist, I haven't had a case where I've had to do it. But I have seen at conferences and in some case reports some interesting results and some good results in this with this technique. Okay, so that's all for this lecture. And I'll be happy to answer any questions when I see you on campus. Thank you very much.